Okay, so you want me to go?
Yeah, that'd be great.
Perfect. Thank you very much. Hi, everybody. My name is Jorge Flores Aranda. I'm a professor at the School of Social Work of University of Quebec in Montreal, UQAM. And I was one of the researchers involved in the feasibility study that has conducted to the development of the first managed alcohol program in Montreal. I'm going to present a little bit of the history of the project, and then my colleagues Rossio and Natalia will share a little bit about the result of these two projects. I have only two slides, which are in French. I'm sorry for that. But this one is a slide that summarizes the trajectory of the project regarding the development of managed alcohol program in Montreal. So the project starts in 2017 with a systematic review. So we conduct a systematic review. The report of the review are available online in French only for the moment. But the goal of this literature review was to describe the different type of wet services or wet shelter or managed alcohol program that were available in the world, and also to assess the efficacy and the effects of this kind of services for homeless people. And the result of the literature review show us that it was a very good services. It was a very good service for people in a homeless situation, and also the literature shown us that managed alcohol program were a good option for people, and it could help for have a better quality of life, also better access to health services, less contact with the police, less criminalization. So we can saw a lot of benefit of managed alcohol program. So then we started a feasibility study in order to know the best way to have the first managed alcohol program or other services for people who were homeless and using alcohol. And so we conducted interviews with experts that were involved in the development of this kind of services. And we also conducted this with in a participatory approach with people from the community, and also with people from community-based organizations working with people in homeless situation. And also we conduct focus group and interview individual interviews with counselors working with homeless people, and also with people who were in homeless situation, in order to know how they imagine the future of wet service in Montreal. So this study allowed us to propose to the Ministry of Health a model of managed alcohol program. And then pandemic arrived, and also there were some organizational issues, economical issues, and also political issues that lead the Ministry of Health to develop another kind of model, completely different than the model that we propose in the feasibility study. So actually there are two managed alcohol programs in Montreal. One is run by an organization named Old Brewery Mission. And the other one is a completely independent of this study project, which is run by an indigenous organization named Projet Autochtone du Québec. So Natalia will speak to you about the first result of the managed alcohol program in Old Brewery Mission, and Rossio will talk about the managed alcohol program in Projet Autochtone du Québec. So actually, I'm going to I will stop the share screen and I will let Natalia maybe talk about the project in Old Brewery Mission.
Thank you, Jorge. Okay, I'm gonna try to share my screen. Just give me 1 second. I don't know what it says that I'm not allowed. Okay, I'm gonna try to share everything. Okay. Can you see the presentation?
Actually not.
No? Okay.
I
don't know why. Or maybe Rossio can start. And
yeah, maybe Rossio can start with the managed alcohol program in Projet Autochtone du Québec. It's okay for you, Rossio?
Problem. I will try to share my screen. Hold on 1 second.
So during this process, so I just going to tell you that
see my screen?
Yeah, we can see. Rossio is a professor at the School of Social Work of Université de Montréal. She's been working in this project since the beginning. So she knows very well the population and she knows very well also the managed alcohol program. So thank you, Rossio.
No, my pleasure. So this is a program that started at the end of 2020, like on December, in the midst of the pandemic. I mean, there were several delays because of the pandemic, but finally, Projet Autochtone de Montréal, that has a partnership about a group of researchers, medical researchers here and practitioners at the CHUM, which is a university hospital unit, and Jorge and I. So they finally decided to start the program. And I mean, it's a small map. It's not a big one. I think the limit of beds at the time was 8 beds. Now it's a little bit, there are more beds. There are 11, I think. But it was always, it never reached the capacity. There were always 5 to 6 residents, no more than that. And well, it started, and at the beginning, it was not like very easy. It was like a group of residents that were like severely alcohol dependent. They were not very happy to be together. There was a lot of fights, a lot of violence among residents, and also between residents and staff. Like the residents were like very violent with the staff in many ways, no? So, but as time passed, I have been going there for more than 2 years. Things really calmed down and they start to become a community. And one of the key elements for this group to become a community was a process of selection that unfortunately, but it was necessary, became more rigid. So this is a program with a high threshold. And the evaluation basically tried to focus on if the person could or could not be a good fit for the community. Okay, so and what we did was to follow the implementation of the managed alcohol program. So we did a qualitative study, and we interview residents, staff members, and people from the show medical team. We also did informal interviews, participant observation, as part of creating relationships for doing the interviews. I am a cultural anthropologist. I cannot do research if I don't do field work. So I think it was not so clear in the protocols, but this is what in practice we did. We established close relationships with the residents, with the staff, and then we start conducting interviews. So we did also volunteer work. We still do volunteer work. I should change this date. We go now once a week to be with the residents and the staff to help in what is needed. So, and our sample for the interviews was 5 residents, 6 staff members, and 3 people from the SHUM team. What are our preliminary results? Because this we finished to analyze the interviews and the field notes we wrote, but we're in the process of writing the article. That's why our results are preliminary yet. So what do we found? So residents reported feeling better and safer. They really like having their own space, their own room, and also have like communal spaces that they can share with others. They perceive that their health has improved, so they immediately pointed out that their sleep patterns stabilize, that they have regular meals, that they receive medical care, and they were having different chronic diseases, and these diseases either they overcame these diseases or they are under control. Something very important to say is that the SHU medical team goes to the MAP house. So they don't have to go to the hospital to reach the medical team, but the doctor and at least one nurse goes to the MAP house. They go to the MAP house like maybe once a week. I think all Wednesdays they go. So the residents, they are indigenous and they don't trust in the medical system because they had very bad experience, or people close to them had very bad experience with the medical system. So this is an important issue. Like the nurse, the doctor and the nurses, they progressively build a relationship of trust with the residents. So they accepted to be treated for some of the health conditions they have. So as an effect of this relationship, this ongoing relationship with the residents, some residents wanted, for example, to treat Hep C or a chronic problem with their liver, or the doctor suggested them, like, seriously, if you want to get treated for Hep C, is much more efficient if you stop drinking at least for I don't know, a few weeks. And some of them, because they wanted to improve their health, they underwent detox. They went to detox voluntarily. from the three that went to detox to treat a medical condition to stop drinking. So this was not the goal of this program, because it's a harm reduction program. So the goal was not that they stop drinking, but it was something that almost naturally came out of a process of implementing the MAP, created a community, establishing links of trust with people from the SHU medical team. So it was an unexpected effect of the MAP. They also reduce their use of street drugs. These are the bright results. There were also some results that were less positive. For example, in the MAP, there is a lack of activities, and some of the residents got bored and started having dark thoughts. So they reported that because when they were in the streets, when they were in a situation of homelessness, they had a lot of things to do to get money for the next drink, finding a place to sleep. They also were like in group with friends and family. So they were always socializing. They were always having something to do, a way to occupy their lives. And then they stopped everything, and all their basic needs were solved in the MAP. So at the beginning, they love it, but then they start to get bored and having dark thoughts. So the idea, so what happened is that they were waiting for the next drink, because the MAP provides drinks every hour. Depends on the plan of each resident, but about every hour they receive a unit of like a glass of beer. So like their focus of attention was waiting for the next beer. Yeah, and they also start thinking about things that were not solved in their lives, in their psychological, emotional lives. So we consider at the beginning that they might need psychological and psychiatric support, but they don't like to talk. I think it's something that the doctor tried, but they really didn't want to talk about their problems. So an elder goes to the MAP like once or twice a week, not to talk directly about the problems, because they didn't even want to talk about their emotional and psychological issues with the elder, but at least to do something with them, build a relationship with them, and maybe in the future they might feel comfortable to talk about these issues, or maybe talk therapy won't work for them. So the elder is considering trying another means, maybe traditional means to address psychological and emotional issues. So then another result was that some of the residents have feelings of isolation or reclusion, because they were part of a MAP and they were like not so integrated anymore to their former social world. So they felt isolated, and that they were not having like a normal life, a regular life. So that was another issue that emerged in our results. And also in the interview with workers, they didn't understand very well the harm reduction approach, and also each resident have a managed outcome plan, individualized, personalized to his specific needs, and they were not understanding the sense of the plans very well. So, and the job was very demanding. So they were like overwhelmed, and there was a very high turnover because many of them had found that the work was the working load was too heavy. They needed like a second person at least in each shift. Only one person is, according to the way the map is designed, is only one person per shift. Also, as I said, there are not many residents, so that's why the administration took that decision. But most of the workers consider that even if at times there is not much work to do, there are moments that they have to solve like 3-4 problems at the same time, and this is not feasible for them. So workers didn't last too long. Maybe there is not a single staff member that stay at the beginning of the program and is currently in the program. The only one, the map coordinator, he was the only one that stayed throughout the process. But the intervention workers, they haven't last more than, I will say, 6 months, maybe. The longest, I think, one intervention worker lasted maybe a year, but that's it. So another suggestion from the residents and the staff is more activities outside the map, so this way can build relationships with people that are not part of the program. Yeah, so that's it. Thank you so much.
Thank you very much, Rossio.
I will stop sharing.
Yes, please.
Okay.
So there is some difficulties for Natalia for sharing her screen. So I'm going to share the presentation for her. And Natalia, just tell me when I change the
Thank you.
slides.
Perfect.
And thank you. I'm just going to present Natalia. Natalia is a research coordinator at Institut Universitaire sur la Dépendance, which is a governmental institution doing research on addictions. So thank you, Natalia.
Thank you.
I'm going to share them. Okay.
Okay, so I'm going to present the experience at the Old Brewery Mission that we have. So next slide, please, Jorge. So a bit, I'm gonna describe a bit about how it's different from the map house that Rossio has told us about just recently. How's the research process and the map experience so far? Okay, next one. Okay, so the map at Old Brewery Mission is a joint effort between the Old Brewery Mission, but also the Mental Health and Addictions branch at the CUs, Centre Sud de l'Île de Montréal. So they provide kind of the clinic support for this map, and the Old Brewery Mission is in charge of the logistics and general coordination of the program. Next one, please. So our program started in April 2022 after a lot of delays, as Jorge explained before. It started with 2 residents only, and during last year, the number of residents oscillated between 2 and 9 in average. But the program has kind of a slow start. So around, I would say around June, July last year, we had like around 4. At some point, we had many residents, like around 9, and currently we have 5 residents at the map. So the map space has a total capacity of 10 beds for the program. 4 of them are individual bedroom, and the other 6 are in shared dormitories. However, the stage with the map is located is shared with other programs at OBM. And the staff assigned to MAP, I think this is also different from the experience from PAC that Rossio told us about. They have one coordinator, one psychosocial worker, one nurse that is provided by the CUs, one person responsible of the pours of the beer, and one animation worker that currently is just going on the weekends, but like in the general picture of the program is supposed to be there full time. Next one, please. So for the admission criteria for our program is has to be a male over 18 years, homeless, with problems of chronic alcohol consumption, but also a history of treatment failures related to alcohol consumption, without an immediate goal of abstinence in the face of alcohol consumption, at high risk of mortality or morbidity, and an autonomous person. And at this program, they receive accommodation and 3 meals per day. The control alcohol consumption, that is also like around 1 beer per hour, depending. There are like individualized plans too. We provide also a psychosocial intervention, leisure activities, and support in the process of adapting to the MAP program, and access to health services run by the CU's team, with referrals also for instance, some of our participants had got a family doctor, things like that, and also the voluntary administration of money, like a trust. Next one. So for the research process that we started April last year, we have conducted 15 individual and private interviews that lasted about 30 to 45 minutes. All of them have been audio recorded and transcribed. We had also like an activity of sharing the preliminary results with participants to kind of validate our results. And we have been also doing participant observations since the beginning of the project in last April. Next, please. So I'm gonna share with you some highlights of the MAP experience so far. Of course, it's not, we have more data with the PAC project. With this project, it's around 6 months of data, but we have some things that we consider interesting. The first thing is that the understanding of the program is generalized between the participants. They are they're not just for control their drinking. For some of them, there's a goal of controlling also their usage of drugs or other substances. For the staff, also it's important that even though the training was not as extensive as we could like, they also have a general understanding that it's about to have a safe place for the participants, that their consumption is totally allowed and shouldn't be judged, which is kind of hard within workers that have been having a story of working in shelters that are not wet shelters, but dry shelters. So in general, in these 6 months, we have reached a general understanding of the program, and the structure of the program also is well received with the participants. The next one. So even though we have been only like around 8 months with this program, there are some changes in their physical and mental health that have been noticing. For instance, there's one participant that says, I'm always in good shape now. I used to sleep in the street, lying in the street. I'm no longer go there. I'm in good shape. I'm walking more. I go to the restaurant. I go to get some food, get to the store to get some chocolate milk. Well, before he was going, at the beginning of the program, he was going to get more beer, but he kind of reached a point of stabilization, it was very important for him. And our other participant says, I would say that the MAP saved my life. Since I've been on the program, I haven't fallen on my head anymore. Since I've been on the program, I don't go on the ambulance anymore. It's been 2.5 months, 3 months since I was in an ambulance. And now no prison, nothing, no blackout. No blackout since I'm on the map. You know, with a blackout, you said, what did I do yesterday? Who did I speak to? Did I play dumb? No, that's over for me. So the participants in general, they are noticing some changes in physical and their mental health. And in general, after a period of adaptation that is about, I would say, 1 to 2 months, they start to really feel the changes in their physical health. So in the next slide, we will see that this is also noticed for the staff. For the workers, they highlight the stabilization, but also how the participants start to take care of themselves, to find a little dignity, they said, to really taking care of themselves and rediscovering their interests. And that's more related to the animation activities, but it's so important. So this is something that the staff has been noticing in this time. And also this other person tell us about the openness and more the relationships, and how being kind of in this group of people that are living together, they are also becoming like establishing some friendships, some also it's kind of a double sword, double side sword, because in this stage where the map is, there are many other people from other programs, so they can talk to other people. There are always people going and leaving, and that it's complicated because it's hard to create kind of a sense of community just within the map program, but at the same time it permits to make a space more relaxed for them, and reduce kind of the fights within with other participants within the map. Next, please. And as Rossio noted here too, we find that there's some source of boredom, of routine, that after a couple of months starts to be shown. So this participant says, to be honest, when I'm in this building, I'm almost tempted to say, you put something in the food or something in the beer or something, I feel so tired, like I never been before. Like sometimes, most of the time, I'm sleep any time of the day, I'm falling asleep, I'm going to lie down, I'm going to sit here, I'm going to fall asleep sitting on the chair, on the sofa. It's probably just because of if I'm not engaged in conversation with anyone or keeping busy, yeah, I'm bored and sleepy, I guess. So this boredom in some participants led to more like a depressive state, and in others to try to find other things to do, like to reach to other community organizations or to reach to friends outside of the map. But it's something that we know that happens also in other maps, so it's something to keep an eye on. The next one, please. And so a little bit about the alcohol management plan. All the participants declare having reduced their consumptions since they are revaluing the program, not only in the number of drinks per day, but also the percentage of alcohol consumed, because many of them were accustomed to have a higher dose of alcohol per day. But it's also important that the nurse at the program have adapted, has tailored on a case-by-case basis the plan. It's important to mention also that there's a frequent problem with staff not following the individual plan, especially because we have a lot of replacement, we have a lot of rotation of staff here, and there are replacements sometimes during the nights and on weekends, so the plan is not follow as the nurse would like, but this flexibility has also allowed for participants to reduce a bit their anxiety about their next consumption and about what's going to happen the next day and what's going to happen at night. So it's been a process to reach a state of peace also with the participants. Next one, please, Jorge. So what could be improved at the MAP so far? One, and this came from the answers from the participants, but also from staff. One thing is the staff training. Some clues to identify withdrawal symptoms, severe alcoholism. According to the participants, the staff training could be improved regarding their view also of homelessness and substance use disorder. The second most important thing is the presence of staff at the bar. We have been observing that there's a lot of problems having someone at the bar. There's a shortage of staff as at OBM, so sometimes the person is not there, and that could delay the frequency of the pours. So that creates a tension with the participants, definitely. Information about the program rules at the beginning. There was a lot of things that were kind of being organized on the go. So for the participants regarding logistic, like laundry or meals or things like that, there were things that were changing and they at some time were confused. I think that has been improved with the months go by in the program, but definitely for the new users, it would be important to have a clear set of rules. Also, the sociocultural animation activities could be improved because currently they only have these on the weekends, and really is needed during the day. As we have seen the quote about the boredom, it's important to keep offered other things to the participants. The shared space situation, because there are so many people around that sometimes there are some beer stolen from the participants, and there could be an easy way to also improve the sense of community within the program. And the leadership and staff rotation, because we have same as Rossio, I have met a lot of staff that have changed. No one from last year is still on the program. It's definitely a demanding job, but in our case we have changed from coordinator 3 times, so that also has an impact on the participants' experience. No? So for us, I think the next slide, Jorge. For us, we are in the last stages of our research process, just kind of closing our process. So thank you so much.
Thank you, Natalia. So Brittany, I pass you on for the next.
Yeah, that was fantastic. Thank you so much for such a thoughtful presentation. I'll press stop on the recording now, and then we can have a quick discussion with folks if they have questions.